Good morning, everyone. Can you hear me all right? Thank you. Thank you to Professor Suresh Komati for his lovely introduction, and I would also like to thank Professor Vaughan Bell for the invitation. And of course, thank you all for being here for this talk. When Vaughan invited me, he asked very specifically for a balanced overview of GLP-1s in psychiatry, mentioning, if you don't mind me saying, that there seems to be quite a lot of hopes, but also a lot of hypes about these medications used in the general medical field. So I've tried to do my very best to tweak my usual presentation and try and cater for that. But in order for that to work, as you will see, I will require a little bit of your help as the audience during the talk. And I very much care about trying to finish on time, despite my Italian origins and so on. So please do help me with that. And only in that way we can make it work. All right? So with that in mind, we jump straight in. A very quick introduction about what GLP-1 receptor agonists are. So they are, if we want to take a bit of a simplistic pharmacological approach to it, they are nothing more but molecules that are very similar to endogenously produced GLP-1, with the difference that the endogenously produced GLP-1 gets cut down by this enzyme DPP4 very quickly, therefore it's got a very short, very short half-life. Whereas these medications here, semaglutide, perhaps the most famous one of all, Ozempic, Wegovy, they're simply resistant to the action of this DPP4. So they can express their action for a longer period of time. And I say their action, I mean that they regulate glucose homeostasis and they work on weight loss. Hence why they were primarily licensed for type 2 diabetes and later on for obesity. If I have to try and give you a bit more of a deep dive, but still remaining at a surface level of the functions of these medications, then I would say, I would summarize them as working on energy, homeostasis, and metabolism within our body. These functions here are about insulin secretion, so obviously more relevant to type 2 diabetes, and these functions here are about appetite. And you can see that there is a delay in gastric emptying that is partly responsible for that, but also these functions here that obviously happen at a central level, and that's where we obviously as neurologists, psychiatrists, neuropsychiatrists and so on start thinking things are getting juicy and of interest for us. Of course, most of this data comes from animal studies, but we do have some evidence in humans too. Now, this is the part that was supposed to work as a bit of a poll, which I failed miserably to implement and transfer in the slides today. So we'll have to do it a little bit the old-fashioned way by hands raising and so on and so forth. So we'll see how it works. So it will work with 5 questions that I'm going to ask. And yeah, we just start quickly with the first one here. So the first question is, in people taking them for their license indications, GLP-1s appear safe from a neuropsychiatric perspective. Is it a promise or a pitfall? Who votes for promise? Can you please raise your hand? Okay, just for the sake of it, who votes for pitfall? Okay, so I'll adjudicate this to a promise. So most people are saying it's a promise, and I would agree with that. Let me give you a little bit of evidence. So this is the most recent systematic review and meta-analysis that I'm aware of published on the topic. It was published on JAMA Psychiatry last year, and a number of very interesting outcomes, but around about 80 trials, more than 100,000 patients. What they saw was that when looking at serious neuropsychiatric adverse events, whether we are looking at them in a population of people with diabetes or a population with obesity, or both combined, there is no apparent difference compared to placebo. So once again, in people with diabetes, in people with obesity, and when we look at them in both, we don't see any difference, statistically significant difference, compared to placebo in terms of serious psychiatric adverse events. And the same, I can also tell you, is when we look at non-serious psychiatric adverse events, and then when looking at specific symptoms that we might have access to, such as, for example, depression. Now let's look at another study on this topic, and I'll spend a little bit of time describing the study methodology to you because it will come up later, okay? So these are real-world investigation that we conducted on a database called Trinetics, which is based in the United States. And what we did, we took a sample of patients with type 2 diabetes, and they were taking either our compound of interest, semaglutide, or 3 comparator medications, sitagliptin, empagliflozin, and glipizide, which are at the same level in terms of line of treatment for type 2 diabetes. So the groups that result from that, which are about 40 to 50K people per comparison, are as similar as possible. We increase that similarity by adjusting for a very large number of covariates that we have access to on this database. And then we just compare them for a large number of neurological and psychiatric outcomes, and then some negative control outcomes, okay? Now, the first thing that we can notice, if we look at this figure here, is that there is an awful lot of gray. And gray, when we are looking at adverse events, is good, okay? And this is what we are hoping to see. So we don't see any benefit here for semaglutide, we don't see any red, so we don't see more favorable safety profile for the comparator drugs. We see a lot of gray, and that reassures us that there is no increased risk across these neurological and psychiatric conditions. Importantly, these are unadjusted hazard ratios. Why are they unadjusted? Because for safety, we don't want to spuriously reduce the chances of not identifying a risk when in fact there would be a risk just because we are adjusting for multiple comparisons, okay? So this is important in terms of safety signal. Now the second question that I'm sure many of you are thinking now is, but I've heard that GLP1s cause suicide. Promise or pitfall? And we do it differently now. If there is a brave volunteer that would raise their hand and can tell me a bit more about that, whether they think it's a promise or a pitfall. No brave volunteer? I'll pick on my friends if you force me. Then again, they've seen my presentation before, so that would be cheating. Graham, do you mind if I ask what do you think about that?
So I don't think it is considered suicide.
Pardon, can you say that again?
So I don't think it causes suicide.
Yeah. So Graham says he doesn't think it causes suicide. So would you call this a promise or a pitfall? It's a bit of a promise. So I'll disagree here. I'll call it a pitfall, but for one specific reason. So let's go a bit more into that. So again, we are thinking about, do these medications cause suicide or not? This is something that has come up a long time ago. With reason, we do know that there are anti-obesity treatments. Most famously, there was the example of rimonabant back in 2012, which was withdrawn due to an increase in suicidality reported. So pharmacovigilance studies picked it up, and the medication was actually withdrawn, and that caused a real dearth of, well, as far as I'm aware, there have been no cannabinoid receptor medications produced since. So it's been a big issue that they found out. So in the same study that I showed you earlier, we looked specifically at suicidality, and you see that there is, again, quite a bit of gray, maybe a bit of green here, so that's reassuring, okay? Then there is a very famous study that was published on Nature Medicine by an independent group of researchers looking specifically at suicidality. They used the same database that we used in this study here, and what they found was indeed that in both diabetes and in obesity populations, there was a reduced, in fact, quite significantly reduced risk of suicide, okay? Now, that's obviously all very reassuring. You can think what you want about a medication being able to reduce suicide and being, that protective. But the argument that I'm going to make here, and why I call this a pitfall and not a promise, is that this data reassures me to some extent that these medications are safe in people who are taking them for their licensed indication. So mainly diabetes and potentially obesity. But we're not necessarily looking at risk where the risk actually lies. So we need to, I don't think we can say anything about safety as yet in people who are, for example, at risk of suicidality because they are depressed, okay? So a bit of a caveat there, especially if we discuss this with our patients. Next question. I think, well, more of a question, a statement. I think that GLP1 receptor agonist will revolutionize the care of several cognitive and mental disorders. So we go back to hands raising. Who believes this is a promise? Please raise your hand. See a few hands being raised. Can you lower your hands? And now, whoever thinks it's a pitfall, please raise your hands. I'm going to go for a 50-50 split here, and I'm pleased to see that, because I'm called this a promise, but it comes once again with some caveats. So I agree that GLP1 receptor agonists will revolutionize the care of several cognitive and mental disorders for a few reasons. So first of all, we got evidence from a number of studies, both preclinical and mechanistic, and clinical studies, that these medications are quite likely to play a role across a variety of neurological psychiatric disorders, okay? Especially if we think about how strongly they can act on mechanisms that are neurobiological, endocrine metabolic, immunological, and potentially also on the gut-brain axis. In particular, if you take a bit more of a deep dive, they seem to work on mechanisms such as brain insulin resistance, BDNF production, inflammatory cytokines, oxidative stress, cardiometabolic problems, and peripheral heart problems, and other inflammatory factors that are very relevant across a variety of psychiatric and neurological disorders. But on top of that, and this is where I really would like to make my point about how these medications are going to revolutionize the care of disorders we are interested in. There is what I will call a low-hanging fruit that is actually a very, very tasty one for us, which is, at the end of the day, we know that our patients, especially the ones with severe mental illness, they don't die of their, let me call it, severe mental illness itself. They don't die of suicide. They die prematurely because of physical health conditions. And most of these physical health conditions are related to cardiometabolic disease, okay? This is an issue that we all know of. It causes a notorious mortality gap of between 10 to 15 years. We all think about it all the time. How much we're doing in terms of reducing this gap, I'm actually not that sure. I don't think we got any good evidence that, despite knowing this for the last, I don't know, decade or so, that gap has really changed. And these medications that seem to be so effective on this cardiometabolic morbidity and mortality, this is just one of the many, many examples that we have in this regard, can make a real difference for a large number, arguably the majority of our patients. So I would say, if we avoid this false dichotomy of physical versus mental health, and we just think about integrated care, chances are these medications are going to revolutionize the care of our patients when we think about these two things together. Okay? Fourth point, so in addition to type 2 diabetes, obesity, cardiovascular disease, and liver disease, etc., we will soon be able to use GLP-1s to treat dementia, addiction, schizophrenia, bipolar disorder, depression, and so on. Who thinks it's a promise? Please raise your hand. A few people, just a few hands. And who thinks it's a pitfall? Many more people think it's a pitfall. So Vaughan raised his hand, so now I'm very aware I'm contradicting the president. I'm going to go for pitfall. So I'm going to go for pitfall. We do have some good evidence that these medications could play a role in these disorders. Okay? I'm going to show you again the same study I showed you earlier. We saw, for example, now we're interested in the greens, and especially we are looking at adjusted results, the ones that are above this line here. So there seems to be quite a good effect for cognitive deficit, maybe dementia as well. Something going on with substance use disorders, especially nicotine misuse, maybe not that surprising, one of the most significantly addictive substances that we are aware of. Something maybe going on with depression and so on. However, you can also see how this can easily become a trap, okay? So we don't really have trials that have assessed these medications robustly in these conditions, and then we start seeing lots of articles saying, oh, these medications reduce smoking, and they reduce cannabis, and they reduce alcohol, and they reduce even suicide, and so on and so forth. Then it starts feeling like, do we believe this? I don't know. I start being a bit more skeptical, okay? However, I don't want to leave you now with something that doesn't sound that hopeful. I think there might be something going on here with this medication that could explain why we are seeing some effects or positive associations across disorders. And I think the key to that might be this more robustly observed association, but also effect in some other studies on cognitive deficit. Because cognitive deficit, as we know, is a massive issue across a variety of both neurological, cognitive, and psychiatric disorders, okay? And if we see an improvement in cognitive deficit, we can see, for example, that there is an improvement in depression scores simply because when we measure depression, we also measure cognition in the scales that we normally use. So we conducted another study, which please take it with a pinch of salt because it's not published yet, in which we had access on this data set, still based in the United States, called NeuroBlue, to very precious data, which is data from secondary care. It's not that easy to have access to this data in, for example, the UK, where we mainly rely on data sets like Q Research from primary care and so on. So we actually had access to patients that had a mental health diagnosis at baseline. So not diabetes, not obesity necessarily, but a mental health diagnosis at baseline, okay? And we use the same methodology that I showed you earlier, comparing semaglutide versus other comparators. The statistics behind it is slightly different, but at the end of the day is very similar. And what we observed was that cognitive impairment, or better, the presence of cognitive signs and symptoms in people taking semaglutide was better compared to people taking the comparator medications, okay? And that was specifically true for two domains, memory and other broader cognitive functions, things like executive functioning and so on. Not so much for attentiveness and not so much for orientation, which to me makes sense because those are the domains that are mainly affected by very acute conditions such as delirium and so on. And when we try to take a bit of a dive into the diagnostic subgroups, then we saw that this association was maintained in depression, not so much. The direction of the association was the same, but the effect was not, the association was not significant in psychotic disorder, bipolar disorder. Still take that with a pinch of salt because it might be due to the simple fact that we don't have big enough numbers in these subgroups, okay? We also conducted an experimental medicine study in which we used a very simple design, randomizing participants to either a single dose, and I'll emphasize this, a single dose of either semaglutide or placebo. These are healthy volunteers, so unbiased theoretically, a quite homogeneous sample, unbiased by any underlying pre-existing condition. And then after 6 to 7 days, they completed a number of neuropsychological cognitive tasks. And in a nutshell, what we saw that people taking a single dose of semaglutide, a single jab of semaglutide compared to placebo, they showed an improvement of what we can call effort-based decision-making, so a measure of in the reward domain, especially a lower level of efforts. They saw an improvement in response inhibition, a measure that is related to impulsivity, and an improvement in working memory, which is more related to what we could call cold cognition. Okay? So once again, there might be some evidence that a transdiagnostic effect on cognition might explain why we are seeing some benefit across a variety of cognitive and mental disorders. All good? With that, we go to the last question, which is GLP1s have arrived and are here to stay. Is it a promise or a pitfall? Who goes for promise? So overwhelmingly unanimous response that yes, it is a promise. So whether you want it or not, so in the media, they've been around a lot. Fitness influencer, they will have to deal with that. And in the academic field, you can see that the number of publications has increased massively over the last few years. And if we look at this article from Science from 2023, talking more specifically about semaglutide, but GLP1s are reshaping medicine and popular culture. And I will argue, as my last message, they're going to do that more and more, because the patents for these medications are soon expiring, okay? So these drugs, which are still quite expensive, are going to be much, much cheaper in a matter of a couple of years, okay? There have been lots of developments. We are starting to develop dual agonists, triple agonists. Medications also work on other related endogenous compounds like amylin and so on that will make these medications more effective and or more specific. And finally, maybe controversially, there have been oral medications that are being developed with the idea that people could keep these anti-obesity drugs in their own, in the purse, and then whenever they pop a pill and they feel like the hunger goes away. So, with that in mind, a bit of a summary of what we said. In people taking them for their license indications, GLP-1 appears safe from a neuropsychiatric perspective. I would say it's a promise. But I've heard that the GLP-1 causes suicide. Maybe it's a bit of a pitfall here. We need more information. We want more evidence before being able to give an adequate, informed response to our patients. GLP-1s, I think, is not hype. I think it's hope that they will revolutionize the care of several cognitive and mental disorders. They will do undoubtful benefit to an awful lot of our patients, but I don't think they are going to be an all-cause remedy that we are just going to give to all our patients with any mental disorder, whether it is a dementia, an addiction, and so on. However, GLP-1s have arrived, they are here to stay, and whether we want it or not, we will have to deal with being able to manage these medications in our patients. With that, I'm done, and I thank you very much for your attention.
Thank you. Thank you for such a clear, engaging, and informative talk. So, time for questions? So we'll go for there.
I can hear you.
Okay, thank you. Thanks for outlining the sort of effects on cognition. Given some of the sort of reports of sort of mild anhedonia that people who are on these medications report, and the fact that the sort of substance abuse disorders are there as well, I was just wondering, is there any neuroscience focus looking on sort of the reward system, salience networks, where the kind of pre and post dopamine occupancy studies, is that all in the pipeline or not done yet?
Yeah, no, thank you. That's an excellent question. So there is a lot of work that has been done in the field. We got quite a bit of work done coming from animal data, as you can imagine. How well that can translate to human samples, I'm not sure. So my appraisal of what we have in the in terms of evidence at the moment, and a little bit from what I showed you in the single dose study that we did, is that the effect on reward might be a bit more complicated than just thinking it causes anhedonia, it dampens reward, it just makes us feel less like we want to engage in any pleasurable stimuli. So I think a good example would be actually to, oops, sorry, slides are gone. Going back to that slide I showed with the effort-based decision-making, we did not observe any effect on reward. It looked like people who were taking the medication compared to placebo, the higher the reward, the more they were engaging with the task, okay? In exactly the way we would expect from any of us. However, they were not willing to engage with the task. They were less willing to engage with the task at lower level of efforts, okay? So I'm still trying to wrap up my mind about what that means, but the best way I have at the moment to describe it comes from what I would call anecdotal evidence. So please take it based on that. So when I speak with patients who take these medications, and they take them for their licensed indication. So I'm talking about weight loss, obesity. What they tell me is not that they've lost pleasure in, most of the time, it's not that they've lost any pleasure in having food, okay? And it's not that they don't feel like having a meal. What they really talk about is this concept that has been in the air quite a bit now, food noise, and they reduce the, what I would conceptualize, low effort way of eating, such as snacking. So they don't go to their cupboard anymore and take, I don't know, crisps, chocolate bar, and things like that, okay? But if it is about cooking a good meal for their dinner, then they still do that. So what makes me think the effect on reward is more a regulatory one rather than a simple, it brings it up or down.
Thank you.
Thank you.
Next question. Thank you. I mean, you presented data for patients on the drugs. We know for obesity, many of those patients will come off the drug, and it's a real roller coaster. Have you looked at the mental health of people who have lost a huge amount of weight and then they put 2/3 back on, and what the effect is in that situation?
Yeah, so that is a massive concern. Many of you might have seen a recent BMJ systematic review and meta-analysis showing very concerning data about people who stop taking the GLP1 drug for obesity, and the really massive weight regain that happens as a consequence of that, even more so than the weight that they begin with, okay? Even more concerning, if you think about that as an average, what that's probably telling us is that there is a group of people where there is probably not going to be that much of a weight change. Maybe they actually do manage to maintain their weight change. Other people that are going to regain really seriously high levels of weight. Now, the impact of that on people's mental health, we don't know. We can all imagine that psychologically that will surely have an impact, okay? And I'm very glad that you raised this point, because I think that should be a very strong prompt to whoever wants to do serious care for obesity to involve us, psychiatrists, and so on, as professionals in the care of these patients, okay? Because otherwise the consequences might be actually quite severe. Now, going from there to say actually these drugs cause depression, because of course people who don't manage to lose weight are going to feel depressed, and then they lose weight, they feel happier, and they regain weight. I think that's a very simplistic way to look at depression. We want to steer away from that. But when we are thinking about the treatment of these people for obesity, then I think this makes a very strong argument. I'm wondering whether you were thinking the same about a real multidisciplinary approach that involves us as specialists for the care of these patients.
Thanks for the interesting talk. In terms of potential psychiatric consequences of these medications, I guess eating disorders are the thing that obviously comes to mind. And eating disorders seem to have exploded in prevalence in recent years. And we're now facing drugs that can facilitate eating disorder becoming a sort of pop culture phenomenon. I mean, that Hollywood size 0 slide you had, I think, speaks to that. Is that something we should be worried about?
Yeah. Yes. I did not bring that up because I am not an expert. I don't work in eating disorders, but as a non-specialist, I am actually very concerned about that. The Hollywood trend is, something that began a while ago, and I was told there is a recent TikTok phenomenon about collarbone, Ozempic collarbones or something like that, and we know how much the younger people could be affected by that. So when we looked at these medications, in that meta-analysis that I showed you on JAMA Psychiatry, we actually saw an effect that could be potentially of benefit in some eating disorders, so a positive effect on emotional eating and so on, okay? On the other hand, again, I'll tell this as a brief anecdote, but that could be quite interesting. Back in 2017, when nobody was talking about these medications, nobody at all, I had no idea what they were. I was just gonna embark upon a very unsuccessful PhD on statins that found absolutely nothing. And I was working in, just before I was working in an eating disorder unit for 6 months as a CT2. And I remember, in hindsight, I remember speaking with this patient, who was a patient with anorexia nervosa, who was telling me about this magical medication that she was getting shipped somehow from the United States, and that she was taking because she had noticed it had reduced her anger, and the medication in question was liraglutide, so lesser-known cousin of semaglutide. So yes, I am very concerned, and I also find quite concerning that at the same time that doesn't seem to match a very good amount of research that is being done on the area. I think most of the research in the area is being done on, I'll call them sexier areas such as dementia, cognitive disorders, and you know, mood disorders and so on. We should do a bit more in eating disorders.
That last question, maybe, I think.
You touched on the appalling death rate in schizophrenia from cardiovascular disorders. Do you think we've reached the point now where if we're starting antipsychotics for maintenance treatment, you should just be automatically co-prescribing a GLP1 inhibitor?
Thank you. It's a very tough question because obviously we are worried about the side effects of the antipsychotics. However, one could argue that instead of immediately starting with another medication, so probably we are thinking the same, if we're prescribing olanzapine, should we be prescribing semaglutide or tirzepatide together straight away? I think, you know, there is probably a better step to do that, which is, should we start olanzapine to begin with in the first place? Could we start with something like aripiprazole, lurasidone, and so on and so forth? So I would argue that. My concern, though, is that that might not resolve the problem still, because we know there is lots of studies that are showing that this increased cardiometabolic risk seems to actually be quite independent or predate the commencement of an antipsychotic, in which case I would say yes, as these medications become more and more easy to, more available, more efficacious, but also hopefully at the same time safer, there might be a good ground for co-starting these patients in the early intervention services even.
Sure. So I'm sure there are many more questions, but conscious of the time, I think we probably have to stop here. So moving on to the next one, and give a good applause.